Thank you for inviting me to speak at this conference. My name is Hilary Bekker and I'm a Professor of Medical Decision Making at the University of Leeds and Aarhus University in Denmark. Today I am talking to you about the concept of shared decision making. So I have 15 minutes to help you think critically about what shared decision making is and what it means to your practice. Basically, I'm an academic. I have been an academic for all my life, and that means that I get funding to be employed as an academic through grants to do research. I get remuneration for visits around training and knowledge dissemination, and on a few occasions, I even get paid for my expertise on advisory panels. I have no regular shares in companies that benefit from designing or delivering or charging for training. So what am I going to do today? So first of all, I'm going to talk about how my perspective as an academic decision scientist helps people understand how patients and professionals make healthcare decisions as individuals and together. I'm going to define shared decision making. It's always useful to do that, just to check that we're all talking about the same thing. I'm going to touch briefly on the challenges for neuro-oncology context and shared decision making, but obviously that's your expertise, not mine. It's not an area I've worked in specifically. And then I'm going to whiz through, we've only got 15 minutes, of interventions that can support shared reasoning about healthcare plans. Really gives the structure of who I am. I am a psychologist. I'm interested in decision science. That's the science from social scientists over the last 60 years that explain how the brain works, how people think, what influences people's thinking, and how we can present resources and information to help people reason well. My applied field for over 30 years has been healthcare. I've worked with patients and professionals and research methodologists to explore how people make healthcare decisions, either as professionals or as patients or together. I design interventions. These are usually complex interventions, if you're familiar with the MRC complex intervention framework, because inevitably, when we're talking about shared decision making or healthcare decision making, it's decision making with multiple stakeholders. And when you're designing an intervention, of course, all the different parts of that have to link together, so it's a complex intervention that we're usually designing to support professionals to reason more effectively, to help professionals engage their patients more effectively in healthcare, to help patients to be involved more proactively in their healthcare. So I'm going to start with my understanding, my definition of what it means to make an informed decision. I think this is what most of us would like to make all the time, and what we hope people are making when they're choosing treatment options in healthcare. So an informed decision is one that is made well. It's based on a person's reasoning about the accurate information they have about all options and their consequences, and without bias. And without bias here refers to how the presentation of information can bias our reasoning, and I'll come on to that later. An informed decision also requires that we evaluate these facts with our own beliefs, so that when we make develop a preference or a judgment, it's based on what we think about it and how it's relevant to our life. And then when we're making a decision, we're trading off these evaluations between these different options to base that on our decision. So that's generally what making an informed decision is. And all humans can make informed decisions. It's just that most of the time we don't make informed decisions. We use different processes to make a choice. And if normally I would provide you with a lot of the decision science, but I can't do that in a 15-minute talk. So I just want you to reflect a little bit on how you make normal decisions. For example, how you chose your last car, how you chose your last smartphone. And at the moment, I'm having new bathrooms fitted, and believe me, there's been a lot of decision making going into that. So I can reflect on how I've made those decisions, where I got my advice from, what information I looked at, whether the choice was difficult or easy to make, whether it was just one choice. And then something to think about is how you make decisions now with a bit more experience of perhaps having cars and phones and bathrooms. Is that different to how you first made your choice? So what you will start seeing there is how we reason and how we think about our decisions and what is influencing our decisions. So, for example, when I first made my smartphone decision a couple of years ago, I was a very late adopter. My provider provided me with 71 options. I had lots of advice from other people around me about how I should choose my phone, whether it was pretty, whether I needed to get Spotify. Everyone in design has an iPhone, not too big, not too small. Where do you buy apps? And then there was lots and lots of text. So loads of information. It was my choice to make. It was a preference-based decision, but it was incredibly hard. And I eventually made a decision based on the camera, not on anything to do with it being a phone. And I still don't know whether I've made the right decision. And actually, I still find it really difficult to choose a phone. And I tend to go with the phone I chose the first time. And I think that is a very normal way, or certainly a normal way for me, to make a decision about technology. So you'll see it's not systematic. It's not an informed decision. I certainly don't feel I've ever made the right decision about a phone. I've made a satisfactory decision. It's fine, but is it the right decision? I'm not sure I will ever know. So what I've illustrated there are two ways that humans make decisions. We can make a choice either through an intuitive or experiential strategy, which is that what people used to call heuristics, fast thinking, system one, which is it's almost automatic. We use this all the time, every day. For most of our decisions, it's unconscious. It's used a little snippet of information that makes our choice. It can be what somebody's recommended, or the color or something, or very, very quick, and we've made a decision. So for example, I went by the brand name, I went the one that my friend had, and so the other used to make a decision is the analytic deliberative one. And this is like the informed decision-making process. It's slow thinking, it's systematic, it's a conscious evaluation of the pros and cons, and it's much more deliberative and can be quite a stressful process. And humans use both of these processes interchangeably all the time when they're making a decision. When we make an intuitive decision, it's fast and instant, and usually it's fine. Although we are more likely to make a wrong decision that way. If we're basing our choice on somebody else's values, we may regret it. For most decisions, it doesn't matter, but obviously in healthcare, if we feel we've made a wrong decision, it has huge implications. And just to be reminded that actually as humans, we have very little insight into what influences our choices. When I asked you to reflect on your thinking and how you made a choice, very often we don't. We don't reflect, unless you're a decision scientist, on how you made that decision. And partly, our decision making is completely unconscious. It is the brain deciding what we are responding to, creating that mental representation of the world, choosing what we attend to, excluding facts, making unconscious judgments based on our past beliefs, experiences. We have very limited capacity for conscious attention, so we're easily distracted consciously while the brain is still processing things unconsciously. So it's just worth bearing that in mind when we talk about how do we support people to make decisions well, is that we need to recognise a lot is happening there, both in the information we give and in the way they are interpreting the information. All I can say is our brains work in the same way, whether or not we're making healthcare decisions or decisions about bathrooms or phones. So as a patient or a professional, your decisions will be based on past experiences and old knowledge, somebody else's choices or values. It may be that somebody's choices are incredibly informed. If they've just written the Cochrane systematic review, I personally would trust that judgment. It's based on our own external, internal cues. If we're feeling upset, if we're feeling stressed, if we're feeling happy, that affects how we process our own beliefs about health and illness, which again is why patients and professionals have slightly different perspectives. Is obviously if you've trained to deliver healthcare, you have a lot more knowledge, you trust it, you know the pros and cons, whereas patients are often coming into this for the first time. And key here is how the information is presented influences our decisions. That can be both a good thing or a bad. Most patient resources are usually designed to inform or prepare people for a procedure. They're not usually designed to help people make a choice between options. Usually the information is designed to support adjusting or coping with an illness. Absolutely, we want to reduce people's anxiety and help them prepare and adjust to ill and move with their lives. When we've analysed the content of routine information, we know it's facts or biases, judgments that can encourage them to make decisions quickly, choices quickly, rather than deliberate. There are some resources that are explicitly designed to support proactive thinking, informed decision making. They are designed that when you write the resource, they boost people's thinking. They give them cognitive space to make a decision and support reasoning between options. They also help people understand more the other people's decision in that healthcare setting or in that care pathway. So they help the patient see the multiple stakeholders in that decision. So this is the framework I use to do when working to state. I recognise that actually decision making is a multiple stakeholder decision. You've got health professionals making lots of decisions to deliver evidence-based practice. You've got patients making lots of decisions about their daily life, and one of those decisions is about their healthcare. Then you've got people meeting together to share their perspectives and their decision making and what's important to them to reach a common goal and action plan. And most of the time this works well. If you think of all the consultations, generally 80% of consultation, there is agreement. We're talking perhaps 20% of consultations where either the health professional hasn't provided the information the patient needs, or the patient hasn't given the information the health professional needs to inform their clinical decisions. And this is where the shared decision-making world sits. It sits in that consultation, that exchange of information. When we define shared decision making, this is the longest, best definition of shared making. Decision making is an interactive process in which patients and professionals collaborate to choose healthcare. It's something that happens in the consultations where both the patient and professional exchange information and knowledge about the treatment options, and about the healthcare problem. They express their own preferences and values, one based on their lifestyle, the other one based on their daily life, and one based on evidence-based practice or specific protocols within a service. Then there comes the reasoning about what works, which treatment works for that patient, and then there is an agreement and implementation of the choice. So it sounds like it's something to train our health professionals to do and patients know. It sounds like that. However, about it if that's what actually happened. There is current guidance and policy to make shared decision making a part of everyday healthcare, which suggests it isn't happening across all healthcare settings. And if we look at the evidence, we can see why. We can see that good consultation skills, those that we train people for, are not the same as good shared decision-making skills. This was analysis of 14 consultations about lung cancer treatment options, and really what I want to show is that there's really good consistent decision making in these consultations about the usual clinical reasoning processes that health professionals are trained in. So the reason for why the patient is present, their history, their social circumstances, developing rapport, treatment processes, preparation for treatment, and side effects. Where things are different are the fact that it's about talking about different treatment options to the one being presented, talking about the evidence for effectiveness, talking about the option to not have treatment or to monitor or to think about different treatments. And then it becomes that personalization of that treatment options with the patient values, where it starts to change and tail off. Second thing to consider is if it's not mentioned by the practitioner, it's not generally discussed by the patient. So here the green is the doctor, the red is the patient, and the blue is the companion. And you can see that when the doctor talks about the disease or the treatment options or the risks, the patient responds. So it shows that the health professional is key to ensuring the right information is talked about in the consultation. So this is a measure of self-report measure of shared decision making. And again, what you can see is the patient is commenting on whether what the cancer professional brought to the consultation, what they brought to the consultation, and how they felt about the final decision. And in red, you can see the components that are associated with a shared decision-making communication. The black tends to be good communication skills. And what you can also see here is that patients generally are happy with the decisions they make, but the process of decision making could be improved. Again, this is your area, and it's for you to reflect. I think there are a number of issues in what I've read about neuro-oncology that suggest this is a very complex and difficult treatment context where you have a number of treatment plans with long-term rehabilitation. Obviously, the tumour itself can impact on how people think, their behaviour, their personality, and also the consequences of treatment can have iatrogenic consequences that change people's health and daily life. Very often you will be introducing issues around palliative care, palliative options, and end-of-life planning. And we know that there are variations in service in how this is brought in and discussed within services and countries. So just to recognise that the context here is going to influence whether people use heuristic or systematic processes. So as I've said before, my field is to design interventions through research about what goes into the consultation. And there are lots of different ways to think about a multiple decision maker here, multiple stakeholders. There are lots of ways to intervene to support a shared process. When you're supporting making the decisions together, more about interventions that target the consultation itself, either through staff training to offer information in a way that is more reflective of shared decision making. It shows the different options. It's how you help practitioners discuss risk figures so that patients can understand it and reason about it. It's about introducing prompts into the consultation. There are a number of brief decision aids or visual prompts to help the explanation of the different options and the reasoning. And there's also prompts around preparing the patient. There's the ask 3 questions prompt. You can give patients a patient decision aid, and I'll talk about that. You could even say there are other types of interventions like completing symptom reporting or patient-reported outcomes that people bring into the consultation that can stimulate that discussion. I'm particularly interested in patient decision aids. I probably don't have very much time to talk about this, but this is what I am particularly passionate about: designing resources that help practitioners reason well, clinical reasoning, to be able to make a medically accurate choice. And you will use these all day in your everyday practice. There are things like clinical guidelines you can see as a protocolized way of best practice. There are now many algorithms and AI to personalize information to the patient using pros. Patient decision aids are the best way, the last 30 years has demonstrated this, to support patients to make informed decisions and prepare them for shared decision making. You can give patient decision aids to patients outside the consultation. They can be accessed through charities or health policy websites, but they need to be proactively designed because they rely on decision science to help people reason well between 2 or more options. And here is just some evidence. You can go to see the type of content they need to include on the IPDAS website, and also the current NICE guidelines, which came out in June, also have a guide to developing patient decision aids. There's the Cochrane review, which shows that if you use a patient decision aid in care, it's more effective than usual practice. And patient decision aids work by providing a structure to help patients see the decision problem, to navigate the way through the decision problem with the healthcare system, to understand what the advantages and disadvantages are of all the options, and to structure the information in a way that supports better thinking. It de-biases the information and it boosts reasoning. It also boosts trade-offs. These are not simple preferences for X or preferences for Y. It's a trade-off. Each option has a pro and a con, and you have to trade off which one you're willing to take. I'm just going to show you some examples here of some of the patient decision aids I have developed, just to show how you can structure the problem to help patients navigate the complexity of a healthcare situation. It took about 10 years to develop this map in chronic kidney disease, to provide a way that both a health professional was able to talk to explain the linked decisions in treating chronic kidney disease as it changes over time. And you can see that this relates to presenting conservative care and dialysis as equivalent options, and enabling that conversation. This is the first decision aid we developed in kidney care, where it was about explaining the dialysis options in more detail. When people have chosen between conservative care and dialysis, they then are choosing which dialysis option. These are ways to show how you present the facts so that it's neutral without bias, and helps patients see what they're trading off, and helps them think about what is important in their life so they can have that conversation with the health professional. So in summary, it's very quick, I realise, but in summary, we know that shared decision making requires services to proactively support patient reasoning between healthcare options. We know that training health professionals to use decision aids, decision coaching skills will lead to more shared decision making communication. We know that patient decision aids are proven, if you want, through randomized controlled trials, are shown to help patients make informed decisions about healthcare, those that are evidence-based and in line with their own values. It also prepares them to make decisions with health professionals to enter in that conversations. I think it is highly likely that decision aids will help patients navigate neuro-oncology. I can see that there's a minefield of clustered decisions there. Personally, as an academic, I would like to do research to understand how you unpack what is going to be useful to help patients navigate that context well and support a good shared decision-making conversation. Thank you very much for your time. Here is my contact email if you want to follow up on any of the issues I raised today. Enjoy the rest of the conference.